emphasize, I will say I welcome you in this webinar. And our main discussion here is furosemide. And I would like to respectively invite our moderator, that is Professor Elmias Terefe, is here with us, one of the faculty, the best faculty in the USIU Africa. Yeah, he is our lecturer in pharmacology, and right now he's taking us through the cardiovascular and renal pharmacology. And now let's start our discussion. Thank you. So our main speakers of this day will be that is Ndungu Isaac. I'm a fourth-year student, Pharmacy, Kenya. We have Namnyaki Daniel, fourth-year student, Pharmacy, Tanzania. Then we have Daryl Anjichi, fourth-year still, Pharmacy. Then we have Rose Mweni, Pharmacy, fourth-year. Then we have Akech Wall, fourth-year, South Sudan representative. Then we have Sophia Gachumia, our Kenyan. Then we have Chelsea Wanjiro, student with a pharmacy student, a Kenyan. So now we have the presentation overview, and we'll first understand what is, because here we are targeting, the talk here is the drug. At the same time, we'll talk about its use in our body. So we'll proceed to understand the physiology. Basically, physiology is usually the study of how the body function. And now once we introduce the drug usage into our body, we come up with pharmacology. So this pharmacology concept is just the study of how the drug operates and the expected outcome that we expect from this drug that we are utilizing. Get the point? So before that, furosemide, this drug is a drug that we usually use as a loop diuretic. And majority, the big name of this drug, we say is a high serum diuretic. High serum because it has high capacity to make sure that it removes from, it removes majority or a large proportion of water in our system. You know, where salt is, water is there. So this drug is usually used for patients who have a lot of excess water in their body, let's say edema, such conditions. Maybe the heart is incapacitated to work appropriately due to excess in the fluid. So this is the most appropriate drug that we can utilize. So finally, we proceed to look for some of the indication, what is it used for? Then we proceed to look for the adverse effects. Then we proceed to see some of the key things that for a patient, for example, upon utilization of this drug, what are some of the monitoring strategies? Because here we are dealing with the patient, at the same time, patient and the people who are in the professionalism. Again, for example, this webinar, the audience, we will talk, even maybe you see a patient maybe at home, you'll be able to see some of these things, and from out of it, you'll be able to have the capacity to monitor. So we'll have all these dynamics and take heed to understand, and in case of anything at the end of the presentation, kindly feel free to ask us questions. So the first presenter who will take us through how the body functions, that is physiology, is Mr. Daryl Anjichi. I hope
thank
my
you, Isaac,
slide is
for giving me
moving.
the floor. Can you guys hear me?
Nice. So Daryl, proceed and mute yourself and proceed. Thank you.
Yes. Okay. Can you hear me, guys? Hello. Okay. Perfect. Thank you. So, as my colleague has introduced me, my name is Daryl, and I'll be taking you through the renal physiology. Rather, firstly, I'll take you through the normal physiology of what happens before we administer our furosemide and what happens after. So, it only makes sense to start our discussion from a point of understanding the site of action of our drug, which is the kidney. So, a little bit about the kidney, rather the anatomy bit of it, is that the functional unit of the kidney is known as the nephron, and we remarkably have about 1 million of them in either kidney, to which and they serve the primary purpose of regulating our fluid balance as well as excretion of solutes in our kidneys. So within these nephrons, within the kidney, still in the kidney, um, it acts as a filtration barrier. So specifically the glomerulus, which receives 20 to 25%, which is actually a quarter of all of the cardiac output produced by the heart. So that's quite significant. Another thing to note in regards to anatomy is we have a phenomenon known as the reabsorption cascade, which is basically happening at the level of the proximal convoluted tubule, or PCT if you like. And here at the site, we have around 65% absorption of, or rather reabsorption of both sodium and water. And why did I highlight all of this? Because our drug, which is furosemide, which, as my colleague rightfully introduced it as a high-sling diuretic, or the loop diuretic, if you'd like, it specifically bypasses these early segments and targets tubular liquid found in the loop. Next slide, please. So now we're narrowing down to specific. That was more of like a general overview of the anatomy of the kidney, or rather the nephron, to be more precise. So where exactly is our furosemide targeting? So our furosemide is selectively targeting our thick ascending limb of the loop of Henle, as you can see from the image. Like what the region that's been highlighted and zoomed into on like the image on the right, that's what we're referring to as our thick ascending loop of Henle. So from here at this site, we have 25% of our sodium filtration being carried out. And a specific feature to note is that this region is impermeable to water. So by doing so, it blocks our solitary absorption. And this in turn has the knock-on effect of impairing our urine concentrating ability. Next slide. So to cap off our discussion in regards to renal physiology and anatomy, I'd like to take you through our electrolyte transport mechanisms. So firstly, one thing that we need to fully understand is our counter current gradient. So what do I mean by counter current gradient? So the thick ascending limb functions to pump sodium chloride into the medullary interstitium. And when it does this, we have some maintenance of like a high osmotic tonicity. And this is important because it helps us with our further downstream processes of concentrating urine. Another phenomenon that we need to understand is our lumen positive voltage. So when we talk about lumen positive voltage, we're talking about the back leakage of potassium ions. And when this happens, it creates a positive potential difference of around approximately 10 millivolts. And this in itself is enough to drive passive paracellular absorption of calcium and magnesium. So if we affect this lumen positive voltage, another application you can have of this is that it would have impaired reabsorption of both calcium and magnesium, and those have various effects. But yeah, that's all I had for you guys today, and thank you for your time.
Thank you, Anjichi. And now, having understood the physiology of the whole system, this is the high time we talk about the pharmacology of furosemide. And Nami or Namnyaki Daniel, take us through the pharmacology. Thank you.
Hi everyone, Namnyaki Daniel, and I'll be taking you through the pharmacology of furosemide. Firstly, the chemical class of furosemide is sulfonyl tranilic acid derivative, and it is a sulfonamide group. And the Arabic name of it is 4-chloro-2-furan-2 methylamine 5-sulfonamide benzoic acid, depending on its structures, we can see it there. And also the key functional group that when you remove it, you'll also get away with the pharmacological activity. It is the SONH2 group for the diuretic potency. It is the sulfonamide group. And it has the hypersensitivity warning, whereby cross-reactivity potential in patients with severe sulfur allergy is more prominent. So if your patient has sulfur allergy with any drug, don't also give furosemide. Next slide. So how furosemide work? First, furosemide acts on the ascending loop of Henle, and as we all know, it is a diuretic. It is a loop diuretic, and there on the ascending limb, it blocks the sodium potassium chloride cotransporter, and it is reversibly binding to the chloride binding site. And when it binds there, it will cause sodium, potassium, and chloride to be removed. So like they will not be reabsorbed back to the tubules, and it will cause sodium, water, potassium, all of them to be excreted. And we should also note that after blocking this NKCC2 cotransporter, due to the positive potential, it will also cause calcium and magnesium not to be reabsorbed. And so loss of potential abolishes the lumen positive voltage, dramatically escalating calcium and magnesium urinary excretion. Vascular and hemodynamic effect of furosemide. First, it is an early vasodilator, like 5 to 15 minutes, where it stimulates the renal prostaglandin synthesis. And we all know that prostaglandins help in the constriction. So when these are in the vasodilation, so when it stimulates it, there will be venodilations of the veins and inducing rapid systemic venous capacitance, which will increase prior to diuresis onset. And it will also cause preload reduction, whereby it reduces the left ventricular filling pressure, providing immediate clinical relief in the acute pulmonary congestion. So that's why people with even congestive heart failure can be given furosemide, because it will reduce that preload.
Thank you, Nami. Well, having covered the physiology and the same time understanding how furosemide work in our system, we'll proceed to talk about some of the indication of the uses of furosemide, then proceed to delve into some of the brands that we have in Kenya that can be utilized for management of this indication. So these platforms, we welcome Sophia for the presentation. Thank you.
I'm going to take you through the clinical indications of furosemide. And one of them is in case of edema. It is the first drug of choice to reduce fluid overload, which may be caused by either congestive heart failure or even cirrhosis or nephrotic syndrome. It is also used in pulmonary edema as an emergency. emergency administration, and it will relieve acute dyspnea through rapid venodilation and intensive diuresis. Another use is in hypertension. In high blood pressure hyper emergencies, or when there is renal insufficiency, where the diazines are ineffective, furosemide will be effective. Next, please. And this furosemide can be found in so many brands here in Kenya, and one of them is Lasix and Furodec. Another one is the generic furosemide, which is affordable and as a single tablet. And another one is Spiromide, which is given as a fixed dose combination of furosemide and spironolactone to prevent hypokalemia. Hypokalemia, that is low potassium levels. Then the dosing and the pharmacokinetics of this furosemide, as we've seen there, furosemide can be given either as a tablet, that is for oral injection, for oral formulation, or it can also be given IV, that is through the veins. And in these formulations, it's found that IV routes, the drugs act faster, and the bioavailability of that drug is 100%. But for oral routes, it's 50% bioavailable, and the duration of action is actually 6 to 8 hours for the oral routes. Then the onset of action, upon administration of furosemide, the oral tablet will show effect within 30 to 60 minutes, but for IV routes, the one that is given through injection, it will show effect within 5 to 10 minutes. Next, please. Then this drug has to be given a maximum of 4 mg IV infusion within 4 minutes. This is so as to prevent ototoxicity. That is the problem in the ears. That is to safeguard the cochlear function and the high dose of this high dose refractory edema.
Done, Sophie? Thank you. Now having known some of the brands that are there in Kenya, we'll now take this opportunity to look into some of the safety and practices that we should consider when we are giving out furosemide. So this gives us an opportunity to give a catch and Rose to address this matter. Thank you.
Hello, my name is Akech, and I'm going to take you through safety and practice. I scroll.
Wait a bit. I don't know why it's not. Yeah, nice. I think noise.
Oh, okay. And then,
thank you. Welcome.
Okay. Then I'm going to take you through adverse effects of the drug. The first one is like the electrolyte depletion or imbalance. So as a result, it can lead to hypokalemia. When sodium channels are blocked, like sodium is taken into like the collecting duct, where again it is like pulled back by the action of aldosterone, and as a result, potassium and hydrogen are like excreted. So it leads also to like metabolic alkalosis. And then hypernatremia, then hypomagnemia, and hypocalcemia. So like, because it leads to this, it requires that you have to monitor the patient continually. And then ototoxicity. So like transient or permanent sensorineural hearing loss with high dose boluses or concomitant ototoxic drugs. Then hypotension and isotemia. Excessive diuresis causes intravascular volume depletion and prerenal acute kidney injury. And then metabolic derangement. So hyperuricemia, that is precipitating gout, and then mild carbohydrate intolerance, that is hyperglycemia. And then absolute contraindication, there's going to be anuria secondary to like severe renal failure, unresponsive to test dosing. And then there will be also severe uncorrected hypokalemia or hyponatremia. And then there's also going to be hepatic coma or encephalopathy associated with electrolyte imbalance. Rose will take us through the next.
Okay, hello. My name is Rose. I'll take you through the cautions and drug-drug interactions. So the first caution, please go back, said hypersensitivity due to sulfonamide medications. Nami took us through the structure of furosemide. It has a sulfonamide moiety which causes hypersensitivity. The other caution will be prostatic hypertrophy or bladder neck obstruction. Here we have a risk of acute urinary retention. And in pregnancy, it causes fetal growth retardation. So you need to monitor closely if you're giving furosemide to a pregnant woman. Next slide, please. So I'll take you through the drug-drug interactions. The first interaction will be with aminoglycoside, example gentamicin and amikacin. Here they have a synergistic ototoxicity, like Akech told us that furosemide side effect will be ototoxicity and nephrotoxicity because it causes damage, tubular damage to the kidneys. Now, together with aminoglycoside, synergistic. The other one is NSAIDs, e.g. ibuprofen and diclofenac. So here, NSAIDs, the drug-drug interaction here, they will inhibit renal prostaglandin synthesis and it attenuates diuresis. So here, furosemide relies on vasodilatory proteins, e.g. PGE, to open renal arterioles. So the NSAIDs block prostaglandins production, therefore constricting the afferent arterioles, reducing the glomerular filtration rate. The other one is digoxin, the cardiac glycoside. So there's a furosemide-induced hypokalemia that triggers fetal digoxin toxicity. The last one are the mood stabilizers, e.g. lithium. Here, there's reduced lithium clearance leading to toxicity. So the furosemide-induced sodium loss triggers like sodium reabsorption in the PCT. The kidneys treat like lithium, like sodium, pulling lithium back to the blood instead of excreting it. So here, decreasing lithium clearance, and lithium is actually toxic to the body. Yes, thank you.
Thank you, Rose, for taking us through the subject matter, the drug-drug interaction. So now, having covered the physiology, pharmacology, how the drug works, the indications and the brands that we found in Kenya or we find in Kenya, and now safety and practices that we should consider or focus on, I'd like to take this opportunity, a bit my slides. Okay, I would like to take this opportunity to invite Chelsea to take us through some of the patient monitoring ways and strategies. So Chelsea.
Thank you. So I'll be concluding our presentation by discussing the patient's monitoring, which is the most important aspect of furosemide therapy. So furosemide is highly effective in removing the excess fluid, but it can also remove important electrolytes, reducing the circulating blood volume. So therefore, we should carefully monitor the furosemide, which is both effective and safe. So for the first one, I'm going to monitor the serum potassium. So one of the biggest concerns about furosemide is hypokalemia or low potassium levels. So furosemide is blocking the reabsorption in the thick ascending limb. As more sodium reaches the distal tubule, the kidneys exchange the sodium for potassium. So this causes more sodium to be lost in urine, and when we have low potassium, it can lead to muscle weakness, muscle cramps, fatigue, constipation, and dangerous cardiac arrhythmia. So it's important in patients taking decoxin because hypokalemia increases the risk of decoxin toxicity. That's why we should check for potassium regularly. It also, we check for serum sodium because furosemide also increases sodium excretion. So if excessive sodium is lost, the patient gets hyponatremia. So symptoms like headache, confusion, dizziness, nausea, and seizures in severe cases. So we need to monitor them, which helps us to prevent neurological complications. Another thing we should check is serum creatinine. So creatinine is a marker of kidney function. So if too much water leaves the body, the blood volume falls and less blood reaches to the kidneys. So it causes acute kidney injury. So creatinine begins to rise, and as it rises, it tells us that the kidneys are becoming stressed at the point, so the doctor may reduce the dose and stop the drug temporarily and give fluids if dehydration is present. Next, we're going to check about blood pressure. So furosemide is removing the water. So less water means less blood volume, and less blood volume means that there's low blood pressure. So when we lower the blood pressure, it's maybe beneficial in hypertension or heart failure. Too much reduction can cause dizziness, fainting, falls, and shock, especially in older patients. So blood pressure also should be checked regularly. And in daily fluid balance, so at this one, we compare how much fluid the patient drinks and how much the fluid they lose. So outputs, the fluid output is when like there's urine, there's vomit, there's drains and diarrhea. So if output greatly exceeds intake, the patients become dehydrated. So if intake exceeds output, fluid overload persists. Also, there's weight monitoring. So daily body weight is actually the easiest ways to monitor the response of furosemide. Yeah, thank you.
Thank you, Shiro. I think you have taken us through a good process of patient monitoring, and now having presented you all those subject matters, we had our references. You can proceed to check for these references for additional information and further grasping of the information that is the talk furosemide. And thank you for listening. Thank you for coming to our webinar. We don't take this for granted. I know in this case or in this juncture, we would wish to receive some of your questions. If you have a question that you require additional comprehension or rather understanding, we are ready to answer. Welcome. Proceed.
I just wanted to clarify something. I haven't really understood. Why is it important, like, to monitor the daily body weight in patients who are receiving furosemide?
Nice, thank you. Another question? Proceed.
I was asking, why is it important for serum creatinine to be monitored as a parameter to be monitored?
Another question? Thank you. Proceed.
I wanted to know, like, what complications can occur if a patient receiving furosemides are not, like, properly monitored? So much.
Please pardon, Zaitun.
I was saying, what are the complications that can occur if a patient receiving furosemide is not, like, properly monitored?
Thank you. Another question? Proceed. Any question?
Hi, I wanted to understand the drug-drug interactions between furosemide and uric acids.
Thank you. Final question, we need 5 questions. If you have any issue or any part of comprehension, already challenge that you doubt that you have not grasped well, this is your platform. Well, proceed.
Why is daily fluid balance important during furosemide treatment?
Thank you so much for such questions. They are very important in matters comprehension of furosemide. So I'd like to take this opportunity to give my fellow colleagues the opportunity to answer the first questions. That's why is it important to monitor the patient body weight? Proceed. That is chance. Okay, proceed. Thank you.
Thank you, Aisha, for the good question. One thing we have to know, a person that is given furosemide is for diuresis, to remove the fluid from the body. And if someone has edema, the body weight of that patient is so huge. So using furosemide, it will reduce the body fluids, and so we are monitoring the body weight so as to assess the effectiveness of the drug. So if the patient body weight reduces after furosemide intake, that will help you know that the diuresis is going well. But also, It will also help you to detect if there is excessive fluid loss. If the patient takes furosemide and the body weight decreases so much, you will know that the person is the person is losing the fluid so much, like there is excessive fluid loss. So it will help you adjust with the problem. And also it will detect if there is any worsening of the fluid retention, and also it will just guide you on the dose adjustment.
Thank you, Nami. The other question was based on why we consider use of serum creatinine in matters cardiovascular disorders and pharmacology. Why should we use serum creatinine as a marker? One of my members, proceed. Any?
Hello. So, why we use serum creatinine? So, serum creatinine, we know that it measures the kidney functions. So, furosemide, what it does is that it reduces the intravascular volume. So, the excessive fluid loss causes a decreased blood flow to the kidneys, causing a rise in serum creatinine. So, here we check the levels of serum creatinine to ensure the kidneys functioning correctly. Yeah.
Thank you, Rose. I'll answer question 3 and 4. That is, what is the main complication that can occur if we just use furosemide without considering or without monitoring it? So as we have seen from our PowerPoint presentation, we have seen that, for example, it causes ototoxicity. Ototoxicity happens in the ears, whereby even an individual is incapacitated even to hear, because you see the same transporter that we have in the kidney is the same as that in the let's say in the ears or something. Another thing about complication is that you find that it's a high serum diuretic. So if we fail to monitor it, we realize that majority of the excess of the fluid will be eliminated in the system, which as a result attract issues, for example, dehydration. Again, looking back at the physiology, we saw that the body is just mainly controlled by some of the electrolytes. You have seen that some of the complications of the furosemide, there will be issue of hyperkalemia, issue of hypercalcemia. Okay, it's hypo. So hypo means that there will be reduced amount of magnesium in the system. Again, hypocalcemia means that there will be that point whereby the calcium levels in the blood tends to reduce. So those are some of the complications. I think they are highly linked to the adverse effect of furosemide. And now under the drug-drug interaction, that is uric acid, it was also an adverse effect. This is an unintended effect of this drug. The adverse effect means it is not intended. So basically, furosemide causes hyperuricemia. Hyperuricemia is the situation whereby the amount of uric acid in the body are high. So in this thing, or in this scenario, you find that the patient has those instances of having gout. So what happens now if you have furosemide and uric acid is that furosemide usually compete with the organic anion transporter, which is one of the transporter that is used for elimination of or secretion of furosemide. So if it happens that furosemide blocks this transporter, which aids in the elimination of furosemide, that means that there will be the amount of or the uric acid in the system will not be secreted by the body or by the kidney. So that means that the levels of the uric acid go high. So that's why furosemide and uric acid are not, they are not all people in the professional, that is the people who are dealing with medicine, are not advised to give those two drugs. You see, the other interactions that we have talked about, even the matter of aminoglycosides, you see, you have seen aminoglycoside, there is that point of ototoxicity. So there are a couple of things that you should note. When you are prescribing this drug, you don't have to give this drug, or if you are there and you are not in the profession, and you see part and parcel an individual who you are closely with him or her using those two drugs, now I think you are now capacitated. Now you have the authority to say from the webinar that I was that these drugs don't work together. So that's the whole point. So for the last question, I would highly take this opportunity to ask my colleagues to answer on my behalf. Thank you.
I'll take the last question. It was talking about why it's important for daily fluid balance during furosemide treatment. So basically, like it helps us to determine whether the patient is losing the right amount of fluid. So it compares the fluid intake and the fluid output. So it helps us as the healthcare providers to assess whether the patient is responding to treatment or becoming dehydrated from the excessive fluid loss or retaining the excess fluid. Basically just guides the decisions about if there's adjusting the dose of furosemide or the fluid intake.
Thank you, Shiro, for answering that question. I think now, having presented well, I think now that everyone is at the par to talk about furosemide, and I hope that everyone has comprehended as much as possible. I hope now you can, whether you are in a professionalism, that pharmacy or medicine or anything, you are in capacity to talk furosemide. So before we close this webinar, I would highly take this opportunity to invite one of our own, that is Professor Ermias Terefe, to have an addition on the webinar. Welcome, Prof.
Thank you. I have nothing to add. I was just listening, and you've done very well. I'm proud of you. Well done, and thank you. That is what I need to say.
Thank you, Professor, for such kind comments. And now we can have a close of this webinar. Thank you guys for coming. Thank you for supporting us. And we don't